Welcome everybody to this year's NYU Department of Neurology Externship Tracks open house. We're going to go through our various tracks tonight, give you hopefully a lot of background so you have a good sense of what we have to offer here at NYU in the Department of Neurology. So just by way of introduction, here are the faculty, or most of them, who are involved in the externship tracks of adult and pediatric. And so most of us will have a word during the process of this evening's open house. And then at the end, there'll be a Q&A. So if you have questions, please hang on to them, and we'll do questions at the end. But here's an overview of where we're going to go and what topics we're going to cover as we move through all the training opportunities for externs at our site. So we're going to go through and just kind of give you a basic overview of the various tracks, and it's 3 tracks broadly, but there's tracks and subtracks and whatnot, but I won't confuse you with that. So broadly, in the Department of Neurology, we have our adult inpatient and outpatient track, and there's 7 positions. And then we have some pediatric specific tracks, and we're going to go into details of what those tracks include. But when you apply, each one of these tracks has a separate wiki application process, and you are absolutely allowed to apply more than one, but for ease of making sure we keep track of everybody who's applying to each position, it's easier if you just apply for multiple, and that's fine. There's no harm in that. We'd rather have redundant than miss you when you intend to apply for more than one. So just a very basic overview to all of our tracks. They all focus on consultation and neuropsychological assessment. There are no intervention experiences in any of these tracks. So if you're looking for some kind of mixed or hybrid experience, this is not the training opportunity for you. It's a very intensive, in some respects, neuropsych assessment experience. And in general, I know some places are still doing hybrid, but our experience is predominantly in person. So you should expect to be on site and doing assessments in person. For the adult track, we do nothing remotely, and there are some exceptions for the pediatric tracks, and the pediatric faculty will go into that. But just to set your expectations, this isn't a fully or just about fully on-site training experience. And just a reminder about application requirements, and we'll revisit this at the end of the talk, but of course you need to be enrolled in a doctoral program in clinical psychology or related area, a PhD or PsyD, and the typical application materials apply, cover letter, CV, 2 letters of recommendation, and importantly, a list of psychological and neuropsychological tests you've actually administered versus learned about it in a course, because those 2 things are a little bit different. Please do not include example test reports. We know at this point that you're at the whim of your supervisors currently, and you're writing their reports in their style. We understand that at this point in your training you have little freedom. So we know we'd be looking at your supervisor's reports. And of course, submit the materials via the wiki site. So I'm going to move on to some details about the adult Manhattan or Manhattan adult track. So it's, as I said, clinical neuropsychological assessment. There are both inpatient and outpatient cases that the trainees see, and they're going to get experience with multiple supervisors. Could be 2, could be 3 supervisors. So there's that opportunity to learn from multiple different people. The externship experience is 2 full days, so 16 hours a week. Unfortunately, Monday is not an option. So Monday cannot be one of the 2 days. And because our didactic experiences are on Tuesdays and Thursdays, one of the days that you pick needs to be one of those days, and then you pick the other day. I've long since given up trying to force people to come on just a couple of days. And our training program is large enough that by the time everybody kind of gets onboarded, we generally have a few different people coming in on the different days. It usually works out. The caseload for the adult neuropsychological assessment experience is about one full clinical evaluation a week. Now, that said, there's ebb and flow in any real clinical setting. There'll be weeks where we're crazy busy and you may be asked to take on 2, but then there's weeks where it's going to be a little slow. And you will have been glad that you took on those 2 cases, because then there may be a week where there's no case. So I've yet to be able to figure out how to make it perfectly smooth throughout the year. It's just the real ebb and flow of a real medical center experience. So, but when things are really busy and you do volunteer to take on a case, we try to give you an opportunity to have a little breather the following week to catch up on work that you may have overloaded yourself with. Our documentation really consists of just reports. There are no therapy or process notes, and our reports tend to range from about 1 to 4 pages. So you will not be asked to write something onerous like 10, 15 pages in the adult track. If you do, I'm going to send you home and say, cut out most of this, because nobody wants to read that, at least certainly not our referral sources. So you will be taught how to write short, how to write to the point, and how to get in and out to communicate effectively the neuropsychological test results in minimum real estate across the page. You're also going to learn about how to navigate the electronic medical records. We happen to have Epic here. But it's a lot harder than it sounds to be able to efficiently get in there, find the information that you need, extract it efficiently, read between the lines. What are the providers trying to tell the other readers, and so forth. So there's a lot of time spent teaching you to be really efficient in this process. It's not a matter of sitting down and reading it, and all the faculty will tell you there's more to it than that. If you would like an example of what our reports look like, we have in the adult track 2 broad styles. We have really short, quick turnaround consults that we do for services that need rapid turnaround. For example, on the cardiac unit, we are asked to do pre-heart transplant, pre-VAD consultations. Is there dementia? Is the person too impaired to be able to list for organ transplant? Those are really fast turnaround. Those need to be 24 or 36-hour turnaround. So those reports are very brief. If you would like literally an example of what a report like that looks like, you just take a look at Lisa Rabden's Handbook on Neuropsychology of Aging, Chapter 40. In the back of that is literally an example of what those short inpatient consultation reports for those fast turnaround referrals look like. If you want an example of our more typical reports, and this could be inpatient and outpatient in the adult track, again, you just look at Dr. Donder's Neuropsych Report Writing book, Chapter 8, and that is a pre-surgical evaluation, an example of our report styles. So we freely publish and make available for your perusal exactly what you might be in for in terms of report writing at our center. Again, not long reports, short, sweet, to the point. Our population in the adult track is hugely diverse. I saw a 94-year-old today, and it wasn't even my first go-round with him. I saw him way back when he was a youngin' at age 92. And that's not the first 90-year-old this year. I've had a handful. Dr. Rush has had a handful. But we also, in the adult track, go down to age 16. Now, I caution you, this is not for educational evaluations. This is strictly, usually in the context of the epilepsy workup or epilepsy pre-surgical workup, where there isn't an element of academic evaluation. I stick strictly within WAIS range, and that's it. So that's our age range. And these folks that we evaluate are coming from extraordinarily diverse socioeconomic, cultural, linguistic, geographic backgrounds, everything you can think of, from the person who's currently coming to you from a shelter in the city to coming from Morgan Stanley halls of the upper echelons of leadership. I made up that Morgan Stanley, it's just the one I remember. I'm not disclosing any actual personal identification there. But that's literally the extremes. And linguistic backgrounds, you absolutely will get experience in working with interpreters because it's New York and you have to. So we navigate all of the challenges of working across culturally and cross linguistically fairly routinely. The clinical presentations are also incredibly diverse. I know it says Epilepsy Center on the front of the door, but you can have a seizure from having a traumatic brain injury. You can have a seizure from having a tumor. You can have a seizure from having a focal cortical dysplasia. You can have a seizure from a stroke or cryptogenic, no idea why. Or sometimes patients just follow at our center because they had a seizure 20 years ago and just are maintained on epileptic medicines, and they need a doctor to prescribe that. So seizure may be somewhere in the medical record, but it definitely is not necessarily the centerpiece to the evaluation. And I highlight that because sometimes trainees become confused about what the experience will include. Oh, I'll just be seeing people with seizures. And that population is by definition hugely diverse. And never mind those folks, our particular referral pattern tends to come from throughout the medical center, as well as, from across the neurology department. So we get referrals from a lot of different kinds of doctors with patients who have a lot of different kinds of presentations, including complex psychiatric presentations. I've actually had 2 individuals with diagnoses of paranoid schizophrenia this year, and that was the presenting issue in my little outpatient office in the epilepsy center. So the biggest thing is don't get locked into the idea that the patient population is homogeneous because the word epilepsy is on the door. So in the adult Manhattan track, there is an opportunity to get some exposure to the WADA procedure and bedside mapping if you happen to be on site when we are doing these procedures. Now, given that the externs are only there 2 days, sometimes the procedures are not happening on the day that they're there. But if they have any flexibility and would like to attend one, certainly we have made arrangements that if they're interested in coming on a day they don't normally come in order to watch one of these procedures, we can figure that out on a case-by-case basis. Our inpatient experience is on the epilepsy monitoring unit predominantly. However, as I've already mentioned, we do a number of cardiac consultations. That's a fairly regular part of our flow. We go over to general medicine. Usually psychiatry is called in to somebody who's got behavioral issues. Maybe they're an older adult and the psychiatrist says, I think this might be dementia, not a psychiatric presentation. Let's get neuropsychology involved. So they bring us over and we get involved in those consultations, as well as assisting general neurology with consultations. The outpatient experience with us over in the epilepsy center is with myself and Dr. Resch. And then over in the Pearl Barlow Center for Memory Evaluation and Treatment, there is experience with Dr. Schulze and potentially next year with Dr. Shahab. So we shall go into some more details. Dr. Schulze, would you like to share a little bit about your setting?
Gladly. Thank you, Dr. Morrison. So my name is Evan Schulze. I'm the neuropsychologist along with Dr. Shahab over at the Barlow Memory Center. And this is really a specialized multidisciplinary clinic with a focus on neurodegenerative conditions. And because of that, most of the patients that we're seeing are more advanced in age. I would say that most patients, if not all patients, are at least 50 years of age. There are some cases where we're seeing patients in their 30s or even 40s, and these are typically patients that have a familial variant of Alzheimer's. But otherwise, I would say the modal age is about 65 or maybe 68, right around there. So we're working with cognitive neurologists, we're working with geriatricians, we have a neuropsychiatrist in clinic, and social workers, all who specialize, in cognitive disorders, specifically memory disorders and neurodegenerative conditions. And we do see quite a range of those conditions. So everything from your typical MCI, early memory changes, or early vascular-related cognitive change, to patients that have genetic mutations, putting them at risk for behavioral variant FTD or FTD motor variants. And I do see quite a few primary progressive aphasias that we tend to track over time because they will progress to a secondary syndrome, depending on the type of presentation. We also see a fair amount of patients that have dementia due to Lewy bodies. Most of the referrals that we're getting in clinic, they're coming from within house. And what's really neat is that they've already had a pretty significant workup usually by the time they get to us. So most patients have had advanced neuroimaging such as MRI, FDG, PET, as well as genetic screenings, which I like to spend time reviewing with my trainees. I think it's so important to have opportunity to look at the imaging and understand the formulation from the neurologist's or geriatrician's perspective to figure out, how are we contributing to this case? And oftentimes it's really aiding in the differential diagnosis. If the clinician's on the fence, we can really help them move things forward, move treatment forward. So what the rotation looks like over at the Barlow Center is 2 days in clinic with us. 1 day would be an assessment day. 1 day would be for scoring, writing, and supervision. That said, supervision is something that's kind of always happening, whether it's discussing the case before we see the patient, checking in during testing, or even after the case. And then there's just additional time to help with case conceptualization that would be on the second day at the Barlow Center, which is the day that would also be spent writing. So the way that we currently have the rotation set up is on the testing day, 2 patients would be seen, a morning case and an afternoon case. And these tend to be briefer evaluations because these are dementia evals. Older patients oftentimes can't tolerate very lengthy batteries. So we reserve 2 3-hour time blocks for our appointments. And then we let the student choose which case they'd like to work on or write up. Sometimes we'll suggest one if we want them to get a little bit more challenging case or start with a more typical presentation. But by and large, I like to leave it up to the students. And then you can see down here where it says assessment days. These are days that both Dr. Shahab and I are in clinic. So I see patients Tuesday, Thursday, Friday, and Dr. Shahab Monday, Tuesday, and Wednesday. So there's opportunity for overlap where we can all discuss cases together, should that be something that fits for a student schedule. Next slide. And as far as our general clinic setting, so we occupy 1 floor over on 32nd Street, or 32nd between Lexington and 3rd Ave. And it's a really nice office space. Each extern has their own office cubicle with desktop computer where they're able to work on their reports and have some privacy to get their work done. And I already talked about caseload a little bit, but again, these are briefer assessment batteries, seeing 2 patients per week. And the reports, much like Dr. Morrison's, are going to be briefer as well, 2 to 3 pages on average. And we like to have students attend feedback sessions as much as is possible. Oftentimes, when there is time, I'll do same-day feedbacks, and that's certainly opportunity for the student to be involved with that process. All right. Well, thank you for letting me talk a little bit about the Barlow Center, and I'll turn it back over to Dr. Morrison.
So now I'd like to introduce Dr. Jennifer Rosenberg, one of our pediatric faculty, who's going to take us through some of the pediatric tracks and perhaps include some of her other pediatric colleagues.
Thank you, Dr. Morrison. So the pediatric tracks are all 2 days per week. So one day would be the full evaluation. Oftentimes you're getting direct supervision, although sometimes depending on where you are in terms of test administration, you might be in another room as we'll go through the tracks and talk about the differences between each location. And then one day for scoring, report writing, and supervision from the case. All testing is in person, and writing and supervision time sometimes is a hybrid, again, depending on the location that you'd be at. Externs are given full remote access, so you'll have all the materials, the electronic medical record, all of your documents are saved to the share drive, so you'll all have access to that even if you're writing from home. And then feedbacks are frequently via telehealth, usually about 3 weeks after the evaluation. Again, it would depend on your individual supervisors, which we'll go through in the next few slides. Sometimes at the epilepsy center, I do feedbacks in person, but I would say most people opt for the telehealth feedbacks. And I know that that's true across different locations as well. We only see patients who have neurological and medical conditions. So at the epilepsy center, that's mainly epilepsy and co-occurring other diagnoses, whether that's genetic or congenital issues, whether that's certainly sometimes we get some of the brain injury and brain tumor, although Dr. Locascio and Dr. Powell will talk more about the individual rotations and kind of how they're weighed in terms of the different conditions that each location tends to get more of. We do not do academic or psychoeducational evaluations. Certainly, we evaluate skills that are relevant for academic functioning, but we don't do academic or psychoeducational evaluations, particularly without the neurological co-occurring condition. Frequently, if that's something that we feel like is we want to look more at, we'll recommend that the school do that piece and then consult. All of the locations are primarily outpatient work. There are some occasional inpatient consultations, although for the most part, I would say the externship is primarily outpatient. And now Dr. Powell will talk about the next slides with the rotations.
Dr. Powell, you're muted.
I'm the only one that did that. I'm so sorry. Thank you, Dr. Rosenberg. So these tracks do have several different locations that are easy to get to via transportation. The first site you'll be at is the NYU Slope Pediatrics in Park Slope, Brooklyn. That's where you'll be supervised by Dr. Gianna Locascio, who will hop on in a couple of slides to tell you more. The Comprehensive Epilepsy Center is where you will work with Dr. Rosenberg, who was just speaking. That is in Midtown Manhattan in the Murray Hill area. And I'm a couple blocks away at the Center for Children's Center for Cancer and Blood Disorders. So we're in the 30s on the east side, very easily accessible by trains. One Friday per month is required for this track where you will be working at the NYU Slope Pediatrics. Our case types range from ages 1 to 24, which is a very wide range. I would say most of our patients are school-aged kids, maybe beginning around 4 years old and extending to 16. I would say that's probably the primary population that you'd be working with in any of our pediatric settings. The primary referral sources are neurology, epilepsy, neurosurgery. We have NF-tologists, neurofibromatosis neurologists, neuro-oncology. Our cochlear implant center refers quite a bit as well. I think that covers like the major referral sources. We do get some from hematology and oncology at my site, but those are definitely fewer and far between. Again, similar to the other sites, we talk about an extremely diverse socioeconomic, cultural, linguistic, and geographic backgrounds. We are often also working with interpreters, mostly when we're speaking with parents. Many of the kids that we work with are and have been educated for many years in the public school system, and so English is their preferred language, although we tend to work with interpreters quite a bit, probably more so than other areas of the country for sure. So I would definitely be prepared for that, and you'll definitely have training on how to work with interpreters, both via telemedicine and also in person. So the Manhattan Pediatric Track is 2 locations instead of 3, and it is the 2 locations in Manhattan. You'll be between the Comprehensive Epilepsy Center and the Children's Center for Cancer and Blood Disorders, working with Dr. Rosenberg and I. And again, our case type is approximately the same age that I had discussed on the previous slide, no real changes there. And it's just a more kind of reduced, condensed referral source list without the general neurology or cochlear implant referrals, more focused on epilepsy, NF, neuro-oncology, oncology, same population. The really only difference between the combined track and the Manhattan track is that you'd also get the experience of working with Dr. Locascio in neurology in Brooklyn, and she has access to a lot of different patient populations that we don't have access to. So it's a great rotation. And I'm going to send it over to Dr. Locascio.
Okay, so I'm going to talk a little bit about just what a typical day looks like. And this applies for the most part to all of the tracks. So whether you're doing a track with all 3 supervisors or with only 2 supervisors, our typical evaluations are last a good part of the day. So depending on the track, you'll start usually around 9 or 9:30, and then we'll generally do an interview with the parents for the first hour or so. Depending on the developmental kind of level of the extern may be doing some testing separately on their own, but for the most part, as we start out, we generally will have the extern with us while we're doing the interview, and then kind of slowly develop that autonomy. And we'll generally have testing run from about, depending on what time the interview with the parents has finished, until around lunchtime. Take a break for lunch. That can vary sometimes for much younger children. Maybe under 5, which I do see a reasonable number of younger children. I would say probably about 25% or so for the track that's with just me. So this schedule will be a little modified. So we might not make it all the way to lunch, or if we do make it to lunchtime, we may have a very brief break, maybe 10 or 20 minutes, and then a shorter amount of testing after. But for older children, they may take, 45 minutes or so break. And then generally we're wrapping up by, I would say 3:30 is typically the latest. Very frequently, it's even before that. But we do tell families, to plan on the better part of the day. So they know that this isn't like a 20-minute physician visit. We do our feedbacks 2 to 3 weeks later. Dr. Rosenberg already touched upon that it's frequently remote. Sometimes families do prefer to come in, and the exact times can kind of vary based on supervisor and location. I just make sure everyone understands that we do all of our testing in one day, including the interview. It's not across multiple visits, which is really the standard in the field nationally for academic medical centers. And every once in a while, there are some telehealth consultation, or maybe a neurobehavioral status exam for a very specific reason. Maybe the family has a very, very limited amount of time, or maybe I do this sometimes where maybe I'm bringing a child in for a very brief evaluation and I want to make it even briefer by having the interview or the neurobehavioral status exam first. But for the most part, you want to plan that you'll be, again, as people have emphasized, you'll be in office doing the testing for the most part, and that feedback may be remote generally. And I think that's most of what we wanted to mention for pediatrics. So I'll get back to Dr. Morrison.
Excellent. So I'd like to introduce Dr. Resch, who's going to take you through our didactic schedule. And this would apply for all the tracks. That's one of the benefits of us working all together, is we can have shared resources and provide the trainees with a real range of opportunities. Dr. Resch?
All right, thank you. So starting broadly, externs if they have availability, can attend a variety of different grand rounds through the departments of psychiatry and neurology, both in Manhattan and Brooklyn. These are virtual lectures covering a range of topics within these specialty areas, from professionals at NYU or at other institutions nationally or internationally. On Tuesdays and Thursdays are the neuropsychology didactics specific to the externship. Trainees of all levels participate in these didactics. So if you're an extern on either Tuesday or Thursday, you would attend those didactics, whichever is your practicum day. If it's being led by one of the epilepsy center faculty, it's usually in-person attendance if you're at or it is required in-person attendance if you're at the epilepsy center. And if you're on one of the other tracks at the time, you can attend virtually. It is hosted hybrid. Whereas if it's hosted by faculty on one of the other tracks, it's usually presented virtually. But this covers a range of topics across the lifespan. So it has pediatric to geriatric content, help preparing you for a lot of topics that you'd experience on the board certification exam down the line. Additionally, the externs participate in a group fact-finding exercise, which is led. The examiner will be one of the fellows. The faculty are in attendance to kind of supervise and provide support, but the fellow leads the externs through a fact-finding exercise where the externs will take turns asking questions and getting some exposure to that part of the board certification exam. Additionally, in the Epilepsy Center on Wednesday mornings, we have a journal club / research lecture series that's features research or article reviews by either the epilepsy fellows, epileptologists, and other people in the Epilepsy Center. That covers a range of topics as well. It could feature case series, other innovative research that's going on, and also sometimes features guest lecturers. Yeah.
Hey, oops, sorry, did I cut you off?
Nope, that's okay.
Okay.
I think I'm next anyway.
Yeah, so we're gonna switch to our virtual tour. The pro of COVID is we get to record this and lots of people get to hear the details of our training. The con is you don't get to come on site and see some of our spaces. So we just have a couple little videos to give you a sense of what some of the spaces look like.
Yeah, so I'll go through these spaces with you as well. It's nice to be able to see some of the spaces that you might be working in. In inpatient settings, rounds might start on the epilepsy monitoring unit or one of the other inpatient floors, where you'd be interviewing the patient or with the faculty member or fellow, and doing testing at bedside. You can see the units have pretty good views of either downtown Manhattan or the East River and Brooklyn. But that's a space where our patients would be staying, and you'd be doing all the assessment in their rooms with them. In line with modern medicine, all of our materials are accessible on our server, which can be accessed remotely from any laptop. So there are a lot of touchdown stations throughout the hospital, either outside patient rooms or in small central offices near nursing stations, where you can kind of grab a computer and get on the server to do writing in between seeing patients on the unit, or to do scoring and or access test materials. So these are a few different examples of what those touchdown spaces look like over at the hospital. And then on the outpatient side of things, most of the testing is done in our outpatient consult room. Here's an example of what that looks like. So large desk, again, access to all of the testing materials, which are on a bookshelf. We also have like a second cabinet full of materials. The consult room is normally shared either between like technicians, fellows, or externs doing testing for the day. We have other office spaces that are pretty similar to this that can be used for testing as well. But like I said, one of the key things is that you can access our server with all our test materials, all the scoring materials from pretty much anywhere that you have access to a computer. So you can use many different types of spaces as touchdown space to get work done throughout the day.
Thank you, Dr. Rash. I just want to highlight that the access to the servers for all of the Department of Neurology externship rotations and tracks. So between all of us and all of our years of practice, we've accumulated quite a lot of tests, manuals, norms, papers on assessment in different languages and so forth. So it's a treasure trove that the trainees have access to. Okay, so let me move on to some of the finer details and then wrap it up. Just a reminder, we follow the CIDNIS Ninja Dot rules. So application submission starts January 8th. Materials should be submitted via the wiki portal, and a reminder of what we're asking people to submit. Our interview process will be held virtually via Zoom. And again, following the CIDNIS guidelines, there's the when we'll start scheduling and when the interviews will take place. So let me just kind of wrap it up and say thank you for attending.